My tutorial presents systemic lupus erythematosis or SLE. Here, systemic refers to multiple organ system involvement, lupus may involve like skin lesions, and erythematosis refers to inflammation or redness. So, SLE is an inflammatory autoimmune disorder affecting multiple organ systems characterized by the production of autoantibodies. And typically, the course of disease is a series of remissions and exacerbations, and virtually any organ of the body may be involved, such as heart, joints, skin, lungs, and blood vessels. The etiology of any of the autoimmune disorders includes genetic predisposition and environmental factors, and in certain cases hormonal factors as well, as SLE predominantly occurs in female, suggesting some of its correlation with estrogen hormone. So, the genetic factors include the genes such as HLA-DR and TQ and non-HLA genes. And environmental factors include exposure to ultraviolet radiation, especially ultraviolet B radiation, smoking, viral infections, silica and mercury exposure, certain drugs, and extreme stress. And hormonal factors include estrogen hormone or female predominance. So, in pathophysiology, if a person carrying a susceptible gene to SLE exposes to sunlight or ultraviolet radiation, these radiations result in the cell damage by programmed cell death or apoptosis. Since apoptosis results in the formation of apoptotic bodies, the apoptotic bodies in SLE mainly contains nuclear antigens such as DNA, histones, and other nuclear antigens and proteins. And in susceptible individuals, the immune cells consider these apoptotic bodies as foreign, resulting in the activation of T cells and B cells, leading to the formation of lots of antibodies. And since these antibodies are formed against the nuclear antigens, they are known as anti-nuclear antibodies or ANA, which are very sensitive to SLE. Now these antibodies combine with nuclear antigen, resulting in the formation of antigen-antibody complexes or immune complexes, and get into the bloodstream of different organs such as kidneys, brains, heart, leading to a local inflammatory reaction. This inflammatory reaction then result in the activation of complement system, which through the activation of an enzymatic cascade result in the cell bursting or the end organ damage. And this end organ damage occurs in healthy cells. Since the whole pathophysiology involves immune complexes, SLE is classified as type 3 hypersensitivity reaction. But in certain cases, there's also direct end organ damage evident with autoantibodies, and hence classifying the disease as type 2 hypersensitivity reaction. So SLE is classified as both type 3 hypersensitivity reaction through the involvement of immune complexes and type 2 hypersensitivity reaction through the direct end organ damage by autoantibodies. So, by the sustained presence of autoantigens, hyperactivity in B cell and T lymphocyte occurs, which result in the formation of autoantibodies. And these autoantibodies against the nuclear antigens are known as anti-nuclear antibodies, and against DNA they are known as anti-double-stranded DNA antibodies, and against RNA they are known as anti-Smith antibodies. And these anti-DNase antibodies and anti-Smith antibodies are very sensitive to SLE. And certain other antibodies such as antibodies against phospholipid, such as antiphospholipid antibodies, leading to the syndrome known as antiphospholipid syndrome, which is a hypercoagulable state. So these autoantibodies then combine with antigens, resulting in formation of immune complexes which then deposit in certain organs such as kidneys, skin, brain, lung, and other tissues, and causes inflammation and tissue damage by a number of mechanisms, for example through the activation of complement system. So in SLE, when the infection is going on, there's increased activation of complement system, and these complement factors are then consumed by immune complexes, resulting in hypocomplementemia or decrease in complement factors. So, hypocomplementemia is considered as a serological sign of ongoing inflammation or active inflammation. So, again, in susceptible individuals, there's loss of tolerance to nuclear antigens, resulting in formation of anti-nuclear antibodies or ANA, leading to an autoimmune response or immune complexes formation, leading to end organ damage. These end organ may involve skin, leading to maculopapular rash or erythmatosis rash. They may also involve mucosa, such as nasal mucosa and oral mucosa, leading to mucosal ulcers. It may also involve serosa, leading to serositis, such as in heart pericarditis, in lungs pleuritis, and in peritoneum peritonitis. And certain other organs, such as joints, leading to arthritis, in vessels, leading to vasculitis, in kidneys, leading to lupus nephritis, and certain neurological disorders, such as psychosis, seizures, or stroke, which occurs due to its hypercoagulable state. So, the general symptoms include fever, fatigue, weight loss, malaise, and anorexia. And here, the multiple organ system involvement is shown, as in skin, the maculopapular rash, in lungs, pleuritis, in heart, pericarditis, endocarditis, in kidneys, lupus nephritis. Musculoskeletal system include arthritis, myositis, sinusitis. CNS involve stroke, seizures, peripheral neuropathy, and hematopoietic system leading to anemia, leukopenia, splenomegaly, thrombocytopenia, and GI leading to abdominal pain due to peritonitis, diarrhea, dysphagia due to esophageal involvement, and certain menstrual abnormalities. So here the maculopapular rash is shown, involving the skin but sparing the nasolabial fold. And other type of rash known as discoid rash, which is also present in the exposed part of the bodies. It is an erythematous fork-shaped discoid rash. And in heart, pericardium involvement leading to pericarditis, endocardial involvement leading to very specific Lippmann Sachs endocarditis. As mitral valve, the vegetations are formed. These vegetations are mainly formed through the combination of fibrin and immune complexes. And at last, the involvement of myocardium leading to myocarditis. So, pericarditis, Lippmann Sachs endocarditis, and myocarditis, all of them are common in SLE. Here again, the butterfly rash or maculopapular rash is shown, sparing the nasolabial fold. Or certain pleuritis, heart problems such as endocarditis, myocarditis, lupus nephritis, arthritis, and the Raynaud phenomenon is shown. So, again, the clinical features include the cutaneous manifestation as rashes, musculoskeletal involvement as arthritis, cardiopulmonary involvement as pleurisy, pericarditis, Lippmann Sachs endocarditis, pulmonary hypertension due to the hypercoagulable state, renal manifestations such as lupus nephritis, neuropsychiatric manifestation as psychosis, seizures, stroke, again due to the hypercoagulable state, and gastrointestinal involvement, that is esophageal dysmotility, hepatomegaly, splenomegaly, ocular involvement, Scandish-Sjogren syndrome, scleritis, retinitis, uveitis. The diagnosis is based on clinical findings and immunological findings. The immunological findings include ANA or anti-nuclear antibodies, which are very sensitive for SLE and are present in almost all of the patients, but they are not specific for the disease, as they are also present in other autoimmune disorders. But anti-double-stranded DNA antibodies and anti-Smith antibodies are highly specific for SLE and confirms the diagnosis. In certain cases, antiphospholipid antibodies are also formed. which include anti-cardiolipin antibodies, giving the false positive syphilis test. And there's also depressed serum complement system or hypocomplementemia, as we have already discussed that complement factors are being consumed by immune complexes and hence suggesting the active inflammation, and antihistone antibodies. So here's the criteria of according to American College of Hematology, which can be memorized by so brain MD mnemonic. Here S stand for serositis, such as in heart, pericarditis, in lung, pleuritis, and in peritoneum, peritonitis. O stands for oral ulcers, but nasal ulcer are also present. Arthritis, which is non-erosive, and photosensitivity. P stands for blood disorder or hematological disorders leading to anemia, lymphopenia, thrombocytopenia, and renal involvement leading to progressive lupus nephritis, ANA titers, immunological phenomena such as anti-double-stranded DNA antibodies, anti-Smith antibodies, and antiphospholipid antibodies, and neurological disorders such as hallucinations, seizures, stroke due to the hypercoagulable state, malnutrition, discoid rash. So the goal of treatments are to prevent flares and treat flares when they occur and minimize the end organ damage and complications. So certain lifestyle changes are made, such as avoiding sunlight exposure by using sun protective screens, which may be effective in preventing the photosensitivity problems such as rashes, discoid or malar rashes. And weight loss is also recommended, especially when the joint involvement is significant or in arthritis cases. Avoiding infection, extreme stress or fatigue, and avoiding drugs, lupus-like effects such as procainamide, hydrolazine. And drug therapy, which include NSAIDs, anti-immunological such as hydroxychloroquine, glucocorticoids, immunosuppressive agents such as azithromycin, mycophenolate mofetil, and methotrexate, cyclosporine, intravenous immunoglobulin therapy, that is controversial, rituximab, baloximab. So in mild cases, such as mild skin or joint involvement, local treatment is done by NSAIDs or hydroxychloroquine. And cases of intermediate severity such as serositis, cytopenia, corticosteroid, azithromycin, and methotrexate are used, which are used as maintenance therapy as well. And in severe cases, intravenous corticosteroids and intravenous cyclophosphamide are used, but they lead to serious complications such as hemorrhagic cystitis or pruritus. So instead of using cyclophosphamide, mycophenolate mofetil is used. And in some cases, such as lupus nephritis, thrombocytopenia or myositis, cyclosporine is used. And the maintenance therapy is done by azathioprine, methotrexate, and mycophenolate mofetil. The complications of SLE involves renal failure, occurs in lupus nephritis, strokes that can occur from active central nervous system lupus, and glucocorticoids complications such as long use of corticosteroids lead to cataracts, osteoporotic fractures, osteonecrosis, diabetes mellitus, obesity, cushingoid habitus, weight gain, and opportunistic infections, and in certain cases malignancy as well. So here is Antiphospholipid antibody syndrome, which is a multisystemic disorder of recurrent thrombosis under pregnancy loss that is associated with the presence of antiphospholipid antibodies. And 50% of the patients with SLE have antiphospholipid antibody syndrome. And we have already discussed that this is a hypercoagulable state leading to the formation of clots, hepatic venous thrombosis, stroke, or DVT. And this is the end of lecture.